Greetings, cherished members of the Mighty Imaging Special Interest Group from the always, sometimes partially sunny Seattle, and a special welcome to all our wonderful colleagues from the AOPT and the APTA. Thanks for joining us in our collective efforts to dismantle the barriers that keep us from actualizing our ultimate macro picture goal of autonomous primary care physical therapy practice. And that for us in our echo chamber means realizing and normalizing physical therapist-directed imaging referral privileges and PT-administered ultrasound imaging. I'm Bruno Steiner. I'm the current president of the Imaging SIG for the APTA's Academy of Orthopedic Physical Therapy. And let's get into it. Originally, I intended to make last month's meeting with Dr. Flynn our last of the season until September, but I got wind of Dr. Matt Schumacher's recent imaging referral-related publication through none other than Dr. Lance Mabry. So I, of course, reached out to Matt and had a delightful conversation about all things physical therapy imaging in North Dakota and the next steps to get full imaging referral access, as they are now limited to a radiography referral alone. So just before taking a summer break to refresh our minds, bodies, and spirits, we absolutely had to end the season with some fresh data and perspectives from Dr. Matt Schumacher, who very recently published Identifying Physical Therapists' Attitudes, Beliefs, and Barriers Towards Diagnostic Imaging Referral, a Mixed Methods Study. His timely investigation took aim at issues facing the primary care physical therapist provider in the realm of imaging referral. And tonight he's going to let us know which physical therapy specialties and which institutional settings may or may not be taking advantage of plain film referral in the Peace Garden state of North Dakota. And we're going to get granular about rural versus urban referrals. So this is a unique opportunity to get an insight on North Dakota's physical therapists' early steps as imaging referral providers, as they leverage their skills to serve the public's health interest in the actualization of primary care physical therapy. And like many North Dakotans who are unsatisfied with the present status quo limiting PTs to plain film referral, I can tell you that Dr. Matt Schumacher will not stop advocating until full imaging referral privileges are granted. Tonight, we are looking forward to his findings and perspectives as he presents Picture Perfect, Unveiling Physical Therapist Perspectives on Diagnostic Imaging Referral in North Dakota. Thanks for joining the discourse and counterpoint as Matt shows you a vision of the early steps in one state's adoption of PT-directed imaging referral, and you may have to suspend your sense of disbelief, but your state may be next. Needless to say, I'm excited by this additional supportive evidence, and I can't wait to hear from Matt and dig into the discourse. But as usual, I've got to get through some business items and some quick shameless plugs for our Imaging SIG members. And then we've got some super exciting developments to report that I'm certain you're going to enjoy as we review our nation's imaging scorecard. First off, I'm going to shamelessly peddle PT-administered ultrasound imaging with this totally inappropriate yet eye-catching font with a selection of sort of cheesy effects. I am so sure that this catchy logo will make you think, well, you know, I really do need to learn and use diagnostic ultrasound imaging. It's so transformational to physical therapy practice, but it is. You must learn it. Here's a quick panoramic look at a 23-centimeter long hematoma from a severe hamstring tear that just came through our clinic. Always an adventure when you're using ultrasound imaging in daily practice at the Washington Center for Bleeding Disorders. And sure, the physical exam will certainly let you know the probable diagnosis of a hamstring strain or tear, but to get the immediate high-definition feedback and confirmation and get the granular about the extent of damage and the extent of hematoma formation is indispensable, in my view, to managing a patient. So you can actually track the resorption, retraction, and mending longitudinally. It's really nothing short of amazing. And similarly, I like using this example of a patient who presented as a chronic tennis elbow that wasn't improving and finally came in to see me. Well, I don't need to explain the value added knowing the extent of injury, which might help your management or referral of the patient. So you can see clearly in this common wrist extensor tear at the lateral epicondyle. You can also see the irregularities of the bony cortex of the humerus, and you can really get a better sense of how you're going to treat this. And like I always say, with practice, you can see what's happening in a matter of minutes or seconds with practice, of course. And just to remind you, the APTA formally declared that ultrasound imaging is a part of our physical therapy professional scope of practice as a response to a direct inquiry from yours truly and the ISIG. And the American Institute of Ultrasound and Medicine recognizes physical therapists as licensed medical providers of MUSCUS, and they offer all kinds of online ultrasound imaging content, and we actively provide ultrasound imaging content for them as well. This has been a great relationship for us. And certainly, speaking of these amazing, important synergies, the gold standard credentialing body Intelios and their registries recognize physical therapist eligibility for their certifications. And in particular, we should all be taking advantage of the incredible privilege of sitting the RMSK physician credential for MUSCUS imaging, governed by Intelios's Alliance for Physician Certification and Advancement. And I would be remiss if I didn't tell you to take advantage of Intelios's POCUS Academy, Point of Care Ultrasound Academy's selection of certifications, which physical therapists are explicitly invited to work towards, including cardiac, vascular, pulmonary, visceral, pelvic, and abdominal, of course, musculoskeletal applications. These are really much easier to work towards than the RMSK, but know that I want all PTs to go for the RMSK and test our mettle alongside our medical colleagues. Because of the interest generated statewide, we are now doing some finishing touches on an physical therapist administered ultrasound imaging resource guide, a review of current evidence, because people are really interested in this subject, and we really need to show that there's a huge amount of supportive evidence for the use of physical therapists of this fantastic modality. So onward, leading off, let me talk about the Mighty Imaging SIGS membership meetings. Just to remind you, last month, the legendary Dr. Tim Flynn presented Imaging Health, the physical therapist's role in disrupting our sickness model. It's caused quite a stir on our AOPT YouTube channel, and like our previous meetings, has generated significant interest. So remember, if you want to check out our previous membership meeting recordings, just navigate to our Imaging Special Interest Group page on the AOPT website, and scroll down to the very bottom of the page, and you'll find the iSig membership webinars, and click your way to the growing inventory of meetings. But you can also check our AOPT YouTube channel for all kinds of AOPT content, including our membership meetings. And I got to tell you, they've been getting a lot of views, a lot of interest. This mainly because of imaging referral being so important in PT administered ultrasound imaging, being so transformational practice, and for our professional relevance, for expedient, modern, quality patient care and physical therapy. So just to remind you, I'm available to take all your questions offline if you want to discuss strategic planning for your individual states, and that's how you should look at us at the iSig, your rapid response resource. Don't plan it alone and reinvent a faultier wheel. So where are we? This is big. Things have changed. I got some fresh news for you. And I keep having to change. We gotta keep on changing our list because with Lance Mabry, who's working on this with me, to try to finalize something, but things are changing weekly. So anyways, let's get into it. First, I'm going to show you the before picture. Then I'm going to show you the after. And I'll show you the areas that I'm actively engaged in. So in dark green, we can order everything. In light green, we can only order radiography, but this has already changed. There's a real appetite for the full realization of imaging referral. In gray, we have practice acts that are largely neutral and silent, which effectively means there's no prohibitions to imaging referral. And what does that mean? Well, no one's really going to stop you from imaging referral, but you're going to have to talk to some radiology practices and centers if they have questions and find it novel to get a referral from a physical therapist. But this has actually been a successful approach for many PTs, but it's a case-by-case basis. We discussed that in Colorado's Scott Rezak, who showed us the way he managed this when Colorado did not have full encoded imaging privileges, and he used the Silent Practice Act quite successfully before they got a declaration. And this map reflects Colorado in the sense that they had a positive declaration from their state board to allow them to image refer. So in red on the map, and this is very alarming, these states have really shot themselves in the foot with explicit language against PT-directed imaging, and these are real setbacks. These states are going to need tough legislative battles to make any gains moving forward. And they're going to have to bring in decision makers and board members that really reflect the current realities of our professional education and the needs of our patients for the sake of good health policy and modern physical therapy. And if these recalcitrant positions can't be swayed and people insist on staying stuck in the past, I really think it's time to step down and step aside. Our membership is growing increasingly impatient with attitudes that are out of step with autonomous, modern primary care physical therapy practice. So ultimately, like I always say, we physical therapists simply want to step up and serve the public's interest in the face of physician and nursing shortages and assume our role as true collaborators in multidisciplinary care. This is the before picture. This is the new map. So let's go. Yeah. It's really great. So let's go step by step. Alaska, we already had good news. The state board actually through a calibrated question and our collaboration, they essentially agreed to all points saying that physical therapists should be referring imaging. They have a special process, though. They have to go through their Alaska administrative code to kind of align departments. So right now, I communicated with the lobbyist Dave Parrish and their APTA Alaska president Alec Kay, and they're going to be talking with the Department of Commerce on July 11th. So we're waiting how steps forward will look like. So, but this is very good progress. The chains are moving forward. Colorado, through a sunset review in the last month, they got official government signature to actually put imaging referral in their Practice Act. So not only a declaration, which would have been fine, frankly, but they have to go through a sunset review every amount of years. I think around 11 years is the next sunset to evaluate whether the profession should even exist. But anyways, they had no problem passing imaging referral. As a matter of fact, they even got prescriptive authority for durable medical goods. So fantastic victory, and even got protections for the branding of their profession. Now, this is the hot news. One of the bits. Arizona now has full imaging privileges. They got rid of the stupid, dumb, annoying language of including ordering musculoskeletal imaging consisting of plain films radiography. So now the practice of physical therapy means examining, evaluating, testing persons with mechanical, physiological, and developmental impairments, functional limitations, disabilities, or other health and movement-related conditions in order to determine diagnosis, a prognosis, and a plan of therapeutic intervention, and to assess the ongoing effects of intervention, including ordering imaging. That's it. Nothing more. That's all we needed. This happened. It literally happened days ago. So it's signed by the governor. Amazing news. Arizona deserves a victory lap. They were not satisfied with just, remember the previous picture was they only had light green. They were authorized to order x-rays alone. They were not satisfied. I know because I spoke with a bunch of people, they were really teed off and they looked for every possible avenue to just jump in and try it again. And they saw their chance and they took it. One legislator held them up last time. It was an ER doc that simply couldn't see us being able to order MRI. They saw their opportunity, they took it, and they're just admirable. They did the tough way, the legislative approach. Anyways, bravo. I'm so proud. It's so exciting. Nevada just they did a calibrated question to their state board, and this is amazing news. They've got full access to imaging. The language is beautiful. It's going to be put up on their website. But here's the kicker. They actually have language in there that basically recognizes physical therapists to practice ultrasound imaging and interpretation. This is huge. The first time for any practice act or any sort of declaration from a state board. So it's groundbreaking. It's phenomenal. So really super happy. This is the work of Dr. Susan Priestman, who consulted with us and collaborated with us and worked and prepped and saw her opening and the timeliness of it. So this three incredible victories within a month. Now I'm actively engaged, optimistic in Montana. They're about to do something pretty significant. I am active, engaged, and optimistic in Wyoming. But one thing happened in Alabama. So in a devil's bargain, Alabama has been desperately trying to get direct access to care for some time now. And in their devil's bargain, they managed to allow some stakeholders to put in the language that they are prohibited from ordering imaging. And even the language prohibits them from really using testing and ultrasound imaging. This is, it's easy for me to critique it. We're really disappointed by this because we would have seen an inevitability of them getting direct access anyways. But, it's easy for me to say, you should have waited. There's all kinds of private practitioners that are desperate for their own businesses to have direct access passed. But we're deeply concerned because you can see how these states are conjoined together, and it just seems like they're influencing and playing off each other. And I think this is terrible. However, I am active, engaged, and optimistic and awaiting for some results from Louisiana. I am active and engaged and optimistic in Tennessee. So we're building a real firewall around this weird metastasis in these southern states. I am active and engaged in Oregon. We've had some real positive conversations. They actually had a new state board member that was asked to join in an attempt to modernize, having a more of representation from a clinical person who really has their ear to the ground on developments in physical therapy. They asked a board question of whether physical therapists should be able to use ultrasound imaging, and they responded yes. Their particular peculiarity is they have to kind of reconcile with a radiology board, unlike other states, but there's reason for good optimism. However, this radiology board doesn't want to talk to somebody internally. They want to talk to somebody externally. So they're asking me to be an advocate, I believe. And that's going to be easy. That's just down the road for me in Seattle. I am active and optimistic and looking forward to the engagement with Nebraska. Some interesting developments in Pennsylvania. Pennsylvania has a unique situation. They had a practice act, really allowed them to do everything. However, they got a recent challenge from a rad tech slash sonography lobby that wants to get licensured. And in that licensure, they wanted to deny us imaging, referral access, and even sonography, when actually people have been doing it in image referral in certain institutions already. So we've had the APTA Pennsylvania's really had a robust response, and we have a really good task force. I've joined in on it and provided all kinds of documentation because according to the rad techs, there's no precedent for us ever having ordered imaging or performed ultrasound. It's very convenient and hardly researched, but it's amazing how people can just say stuff and not even research and not even include us in the conversation. Well, we're in the conversation now, and we are actively engaged. So I'm really curious to see how this is all going to transpire, and all this stuff, all these circles. We'll probably have results by the time we resume our membership meetings at the end of September. So stay tuned. There's going to be a lot coming. And I think it's going to be super exciting. I'm really, really optimistic. So anyways, and of course, we have to mention this anytime we can. The military branches have no prohibitions. They've proven the efficacy of PT-directed imaging referrals since the 70s. They're doing muscus as well. And, it's being taught actively by the likes of John Umlauf. and really exciting things there as well. So anyways, this is the policy and freedom of practice or craft that we want to emulate in the Center of Medicare Services and all state law opinions and rulings. And one thing I have to mention to you, even with these lifting of prohibitions or the codification of imaging privilege rights, this does not allow us, or rather, Medicare as a payer, Medicare and Medicaid as a payer will not pay the radiologist if we refer Medicare patients. So that's one thing we're going to have to fight in the future. But for right now, these are real fantastic victories. So anyways, you should all be happy. This is just amazing stuff. It's just put a huge smile on my face, and it should on yours as well. Back to the main event. Picture Perfect, Unveiling Physical Therapist Perspectives on Diagnostic Imaging Referral in North Dakota with Matt Schumacher. Dr. Matt Schumacher attended the University of Mary, receiving a Doctor of Physical Therapy. He's completed post-professional training, including the board certification of orthopedic clinical specialists, and graduated from Bellin College's Orthopedic Manual Physical Therapy Fellowship Program. He's currently enrolled in the Doctor of Science program there with the expected graduation date of April 2025. Matt's currently an assistant professor at the University of Mary DPT program in Bismarck, North Dakota, and continues to work in orthopedic clinical settings, PRN, outside of his full-time teaching responsibilities. To no one's surprise, his main research interests are in diagnostic imaging, mechanisms of manual therapy, and post-professional education. Please, please, please welcome our dear colleague, Dr. Matt Schumacher. And with that, Matt, I am going to unshare, and you can take it away. Sorry it took so long to get through that stuff, but this is really historic stuff, Matt. So
Absolutely.
welcome.
Well,
Welcome.
thank you very much. I appreciate it. And yeah, I was excited to hear your news there. That's extremely exciting. As Bruno mentioned, my name is Matt Schumacher. I appreciate the opportunity to hop on this evening. I was excited to get an email from Bruno, and Lance connected me with him. And so very excited to share some of the results of a recent study that we just got published here in Journal of Manual Manipulative Therapy. And so, title tonight is Picture Perfect, Unveiling Physical Therapist Perspectives on Diagnostic Imaging Referral in North Dakota. So before I even move on, I have to obviously give credit to my colleagues that helped assist me with this project. And so Dr. Jason Hogan, he's an assistant professor here at the University of Mary. He helped assist with this project. And then this was a faculty-led student research project within the University of Mary. And we had 4 fantastic third-year Doctor of Physical Therapy students that helped us with this project that are now graduated and moving on and doing great things. And so Kendra Carl, Matthias Stitch, Christopher Dean, and Sarah Lawson, I have to give credit to the team because this was definitely a team effort, and I appreciate their willingness and help with this project. So I just wanted to introduce myself just a little bit as well. As Bruno had mentioned, I am a graduate of the University of Mary PT program in 2016. I got my manual therapy certification and board certification in orthopedics in 2019 and 2018. I'm a fellow of the American Academy of Orthopedic Manual Therapy. I am also a student and hope to be done here very soon with my Doctor of Science in Physical Therapy. And as Bruno mentioned, I am also a clinician outside of my teaching obligations, which I hope to speak to a little bit in regards to this topic here in future slides. I am married to my amazing wife. She's an occupational therapist, and this picture is us at Grand Teton National Park, one of our favorite places in the world. And so we travel as much as we can, but then you have kids and they make it very exciting and very busy. And so very grateful and blessed and have a busy household. And so those are my 2 little ones, Noah and Cohen. And then, as I mentioned, I am an assistant professor here at the University of Mary Physical Therapy program. I mainly teach in our orthopedic content in the program. But in that, I also teach our diagnostic imaging content for our students. And so that's a unique area that I teach and very excited to do so. This is our recent graduated class of 2024. And so this is probably one of my most exciting days as a faculty member. I get to celebrate and see the growth of our students. And I work with some amazing colleagues. And as I mentioned, I work part-time PRN, depending on the time of the year, at a local clinic in town here, CC's Physical Therapy, and very fortunate to do that as well. So, as I mentioned, how I kind of came to be able to speak here this evening, I am very fortunate that our recent study got published in Journal of Manual Manipulative Therapy as of April 19th of this year. And so in the next couple slides, I really just wanted to highlight how we came to this study and really what sparked the interest of why we decided to really pursue this topic moving forward. If any of you are looking to access this article, definitely reach out. I'm happy to share this with anyone who's interested. But yeah, wanted to speak to kind of really why we decided to really move forward with this study specific to our physical therapist attitudes, beliefs, and barriers towards diagnostic imaging referral in the state of North Dakota. And so really how we came to the study is, again, having the ability to perform this skill within our scope of practice, something that we came across as out of August 1st, 2021. Extremely grateful for all the work that was done. I wasn't a part of that process, but I've heard the work to get there. And again, I'm extremely grateful for everyone's work to get there. As Bruno mentioned, North Dakota is one of those states that we currently have plain film radiographs in our referral, but that's currently it. And so, also speaking around the state, I know that's something that we're looking to pursue moving forward as far as looking for further advanced imaging within our scope. And so, again, very thankful for that. I know Dr. Scott Brown was on several months ago, and really kind of spoke to that process. So I definitely don't want to dive into that specifically, but obviously we have it within our scope. And from my personal experience, as well as, just speaking with different physical therapists around the country and around our state, is that implementation has been challenging. We have this and really diving into, well, why are we not, fully using what we have available within our scope of practice? And so being in academia, being a researcher, but also being a clinician, had some unique experiences across all domains of this, and really started asking some questions with many clinicians around the state of how are you doing this and what's the process been looking like. And then when we did a literature review, obviously we found many articles on this topic, and I'm very excited, having done that literature review, to see all the research that's out there for physical therapists to be able to use this. And one study that really jumped out to us to really kind of help set the tone here for us was this study by Rundle et al. In 2021, really surveying all the physical therapists as far as their attitudes, knowledge, and behaviors on this topic. And some of the big things that we found or identified that I hope to speak to a little bit more later in our discussion was that doctor of physical therapy degree and post-professional training does seem to result in PTs being more likely to refer, at least in their study, and that about 80% of them do feel confident being able to perform and refer for diagnostic imaging. And then many of them also feel, about 3/4 of them feel that they are referring for diagnostic imaging would improve the ability for them to treat their patients. And when we read that, again, there was an amazing amount of data in this study that really helped us to kind of formulate some thoughts on this process, but definitely some limited information on barriers as to implementation. And so we wanted to look more specifically in that, and that's, again, another reason as to why we decided to pursue this topic. And then Dr. Lance Mabry, again, has come out with two exceptional studies in the last couple of years here. And this is definitely one that jumped and sparked our interest regarding awareness of diagnostic imaging referral, an observational study. And so big thing that we noticed too, again, is 42% of PTs in the United States in their study are aware of their ability to directly order diagnostic imaging in states that allow imaging referral. And so, again, that number isn't as high as I would like it to be. And so we saw that obviously awareness is a barrier for our profession, and that we need to continue to advocate not only to other medical providers, but within our own profession, that this is something that we can do. And then Dr. Mabry also found, right, if you have this, those who are practicing with imaging referrals within their state legislation, as well as those being aware of their imaging referral scope, are more likely to refer and use these privileges. However, at the time of data collection, North Dakota was not a state that was granted imaging privileges at the time. And so also speaking to that, we wanted to more specifically dive into our own state and look at this specifically. And then also in my academic role, as I mentioned, I teach this content in our curriculum, and I know that these are two major studies that have come out, 2014 and 2024, with this recent update, talking about just imaging content in DPT curriculum. I know that there's some variability in many programs, and I recognize in academia there is going to be variability, obviously, and so the imaging section came out with that publication or that manual to help with imaging curriculum, and so we've definitely utilized that. What I've noticed is it definitely seems to be improving in consistency. Average curriculum content is 28 hours, and since CAPTA, required this accreditation of imaging in 2016, I think that seems to obviously be making headway within our curriculum moving forward. And so, again, just wanted to highlight, I'm not going to go into these studies in detail, but I think, again, the research on physical therapists being able to perform this judiciously and appropriately is obviously out there. And again, I'm very grateful for all the work by many of these researchers that have led the way, and there's many more that I haven't included on the slide, to allow us to really dive into this literature and see, gosh, as PTs, as primary care providers, we are in a prime role, and we are doing this amazingly, and we should continue to advocate for our ability to do this moving forward. And why are we not doing it? So that's really where the question came from. And as I mentioned earlier, I practice part-time in a clinic outside of my full-time teaching obligations. Looks a little bit different depending on the time of the year. But being surrounded by these very smart clinicians and individuals, we have many conversations about, why are we not doing this, and how can we work to get this privilege within a private practice setting, which I will speak to a little bit more in some of the results that I found within our study. And so having those discussions, being a researcher, academia, and then also being a clinician, really kind of sparked this interest of trying to explore this more specifically and not really seeing it out there currently. And so we decided to then move forward, and as every study has to go through, right? We achieved IRB approval through our university. We sent this survey out to all licensed physical therapists in North Dakota. We posted through social media advertisements through the APTA North Dakota page, which we were grateful for. I think probably our best recruitment strategy was definitely sending this out to all licensed physical therapists in North Dakota through the NDBPT. And with that, we were able to get quite a good response number. Any of those that are interested in interviews after filling out the survey provided their name and email, which we were fortunate. And we collected data. We performed a statistical analysis, and I'll speak to that a little bit more in future slides, of a binary logistics regression. And then we performed our qualitative analysis, trying to identify any sort of themes from our one-on-one interviews with all these licensed physical therapists in North Dakota. And so this was a figure just taken out of our study. We had a total of 154 respondents, which we were pretty satisfied with. 7 of them were excluded, 5 not being licensed physical therapists in North Dakota. 2 did not agree to complete after starting. So we ended up with a total of 147 participants who completed the survey. 17 interviews were conducted within those 147 who agreed and participated in those as well. This was a table 1 from our study, as well as just some demographic information, just to kind of highlight the demographics of our participants. You could see here that many of them had several. We had a good variety of differing years of experience as far as physical therapists in their career. Majority of our participants did have their doctor of physical therapy degree, and you could see that there as well, as at 77.6%. As far as post-professional training, we really dichotomized that to either you had it or you didn't, and specifically any sort of fellowship training, board certification, specialization, or any sort of residency training would fall into that category. And so we had about 21% of our participants had some sort of post-professional training, and the remaining did not. And not surprisingly, we had majority of our participants were practicing in an orthopedic setting, with geriatrics in a second position there, but not surprisingly, that orthopedic setting seemed to be our highest respondent rate within an area of practice. So some of the results that we found, and then I'll get into a little bit of discussion and kind of comparing what we found with some other studies that are out there. 74.1% of our participants reported that they were not currently directly referring for plain film radiographs. And again, in North Dakota currently as it stands, plain film radiographs would be our form of diagnostic imaging referral, or diagnostic imaging referral, sorry. So you could flip that number though and say that over 25% of our respondents in North Dakota are referring for direct imaging referrals. And then in addition to that, over 70% of them did feel that the ability to refer for diagnostic imaging would improve their ability to treat their patients. Almost 12.2% or 12.2% were unaware of the ability to refer for plain film radiographs. And so if you look back at some previous studies that have been reported, this number is slightly lower than some previously reported literature out there. And again, if you look at those states where imaging was in there within their jurisdictional scope of practice, that number would be lower. However, this was a little bit lower than some of the previously reported literature out there, but still nonetheless 12.2% was higher than what we were expecting or hoping for. Over 80% did indicate that they haven't engaged in any sort of continuing education related to diagnostic imaging in the past 3 years. I'm going to speak to that a little bit more as far as what we found as far as barriers within our quantitative and qualitative analysis. Then almost a quarter of our participants felt that they didn't receive any sort of adequate training while in PT school. But if you looked at the data, majority of these participants did not have a Doctor of Physical Therapy degree. And so again, with CAPTE making this accreditation requirement in 2016, that may make sense that they just didn't feel they were properly trained. And so they had to rely on continuing education to be able to perform that confidently. This was a table from our study regarding our binary logistic regression model with adjusted odds ratios. And so I highlighted our significant values on the side. And really what we looked at was 3 main things. Are you currently referring for plain film radiographs? Have you taken any sort of continuing education on this topic within the past 3 years? And did you feel prepared to refer for diagnostic imaging from your education? And so a couple things I want to highlight here. Again, if you had post-professional training, any sort of fellowship training, board certification, residency training, you were 359% more likely to refer for plain film radiographs versus not having that. And again, that was statistically significant. You can also see the confidence intervals there. Having a doctorate degree, and we dichotomize that as either having some sort of Doctor of Physical Therapy or terminal degree, or not having a doctorate degree, you were 284% more likely to refer for diagnostic imaging. Also, practicing in orthopedic sports, you were more likely to refer versus not practicing in those areas. And then one thing that we did do as well is we looked specifically at the rural and urban part of North Dakota. And so how we dichotomized that was if you were practicing in Bismarck, Fargo, or Grand Forks, the 3 most populous areas in North Dakota, we did find that if you were practicing in those areas, you were more likely to refer for diagnostic imaging versus not practicing in those areas or more rural settings within North Dakota. You could also see that post-professional training did result in a greater likelihood of having taken some sort of continuing education in addition to practicing in ortho or sports setting, as well as living in an urban part of North Dakota. And then, not surprisingly, we had to throw it in here though, feeling prepared from your PT education. If you had a doctorate degree, you were 2,232% more likely to feel that PT school provided you with adequate education. So we added that in there. Obviously, practicing less than 5 years, you would likely have your DPT as well. But clearly, the Doctor of Physical Therapy degree is preparing our students and our graduates to be able to perform this appropriately, and they are feeling confident and prepared to be able to do this outside of school. So what are some of the top barriers that we identified in the survey? And so have 5 barriers that we identified specifically here. And the number one was by far the logistics or just the capability of referring for diagnostic imaging. And so what did that include? That looked at electronic medical records or system and being able to actually perform it through their EMR system. That looked at just not really knowing where to start or how to do it or who to contact. So those are some examples of the logistics. The second top barrier identified in our survey was that this privilege was only exclusively reserved for other healthcare providers in their setting. And so somehow administration prevented a physical therapist or whatever the case may be to actually perform this. Somewhat related to that was provider work relationship difficulties, maybe not necessarily administration only reserving this for other primary care provider roles within their facility, but maybe just not having a difficult relationship to work off of to be able to do this. And the last two identified in the survey as far as barriers were related to continuing education. And so number 4 actually turned out to be the overall cost of continuing education, which also may be tied in with the lack of employer support or looking into courses that would assist them with this. And the number 5 reason or barrier was inability to identify any sort of continuing education related to diagnostic imaging. And so those were the 5 barriers that were identified within our survey, just running frequency counts here. As far as our qualitative analysis, we identified 5 main themes after going through the whole process. And I share a table here on the next couple slides to highlight those themes with specific quotes that supported each theme. And so the first theme that we identified as far as our qualitative analysis was just background in education. Majority of PTs definitely viewed this as a positive attribute to their scope of practice. However, some PTs reported just not being properly trained or not identifying any sort of continuing education to assist them with this topic. Many stated they probably need to take an extra education course to be able to form this. But again, overall, the support was great, and the ability to think that this is definitely a huge part of our practice and a step in the right direction. The second theme that we identified within our qualitative analysis was regarding, again, the logistics of diagnostic imaging. So that definitely seemed to jump up in both analyses. But as far as the logistics, again, as I mentioned, depending on whatever practice setting you were in, definitely seemed to jump out to us. So, for example, one participant mentioned practicing in a private practice and feeling like there were definitely more hoops to jump through versus, not having that, or having a hospital or a physician-owned setting, not having your own radiology department to refer to. And so they had spoke to that specifically. In addition, depending on the setting you practice, such as an acute hospital setting, they were told that they were not to step on other professions' toes because that was not something that, again, administration was allowing at that time. As many participants mentioned, rather, the biggest barrier was just not knowing where to send the patient or how to get the patient in, or really using any specific software, or actually knowing how to write the referral. And so that was something that was brought up in many of our interviews as well. And then some of them, again, we're doing this. And so they just spoke to the length of time it took to get to where they are able to do it, and the convincing of leadership that's something that physical therapists want. It is within our scope of practice, and making sure that we can show the value of what we can do here. And so many participants shared their experiences of how they were going about that and the success stories there. Our third theme that we identified was also related to personal experience. And so many shared their own varying personal experiences in relation to this topic. Many of them felt that they had the necessary skills to be able to perform this. However, recognized that they needed, follow-up courses or things like that to really just improve their confidence in being able to perform this. Obviously, many people had different education background when it came to this, and so they spoke to that. And then one actually, we added here as far as a quote, just spoke to how they had a patient in the hospital. They've fallen, they had a radiograph, they still weren't doing well. They were working with them daily, and they were trying to get them in for another imaging study, and had just taken time to contact the physician. And she ended up having a fracture, and took several weeks and healthcare dollars to figure that out. Whereas the physical therapist, if they would have had that, it would have just been nice to them to do it themselves. And so they spoke to their experience. The fourth theme was really positive. Everyone felt that this is a step in the right direction. Everyone felt that this is a great avenue for our profession to become direct access primary care providers. And they also spoke to that relationship that we build with our patients and the extra time that we get, maybe in relation to other healthcare providers, definitely puts us in a really unique situation to allow us to make more clinically informed decisions and have adequate data to make that, just working with the patient quite regularly. And then the last theme within our qualitative analysis that we identified was awareness. Not only awareness within other medical professions, but also awareness within the public and even awareness within our own profession. And so we had many that spoke to, again, their challenges with other physicians or primary care providers, not knowing that we are able to do this, administration being a barrier. And then we had one participant said that they're allowed to do it, they just didn't know until they read the survey. And so again, kind of an awareness issue within our own profession, as Dr. Mabry's results had showed that, in previous studies as well. So, after going through this process, some of the things that we kind of reflected on after going through this, well, if you look at, again, the percentage of our participants, and again, I think we had a really good overall turnout for the number of participants in specifically the state of North Dakota. Over a quarter of our participants are referring directly for diagnostic imaging plain film radiographs. And this does, if you look at the previous literature, this does seem to be a little bit higher than previously reported. And so we thought that was a great thing to see. We also found that there were similarities with previous literature. For example, pretty consistent percentage as far as confidence and feeling like it would help improve their outcomes. And so it definitely echoed what we found with previous studies reporting the same findings here as well. And as I mentioned previously, right, awareness is an issue within our medical providers, within our healthcare system, within our own profession. And so continuing to get the word out and advocate for what we do as physical therapists is extremely important and beneficial to be able to do this and do it well. We identified many barriers regarding diagnostic imaging. Again, the logistics of just how to do it definitely jumped out there. Continued education, background and education, depending on who we spoke to. But one thing to note that is interesting is, I know the doctor of physical therapy has been something that's been relatively controversial depending on who you talk to in the last several years, at least from when I was a student. But one thing to note in a lot of the studies, and this is just specific to diagnostic imaging, is that doctor of physical therapy degree is noteworthy to see that it is producing and consistently allowing our physical therapists to be able to perform this, order it routinely and appropriately, and in addition to other things as well, as like practicing direct access. And so having that doctor of physical therapy degree is allowing our physical therapists and graduates coming out of school feeling confident to be able to do this. So that's great to see. And then, as I mentioned earlier, something that I didn't really speak to in the results, but definitely was brought up in the introduction here, but something that unique about the rural aspect of North Dakota, when we spoke to many participants, many of them were not practicing in an urban area. They were practicing in a rural area in their small communities across the state. And they were the primary care provider within their own town. And so they were looked to like that. The community viewed them as their primary care provider. They were supported by other primary care provider roles outside of physical therapy in and around the area. The main barrier for them to be able to form it was related to insurance, and Medicare being their primary patient population that they were treating. And so that was something unique that I also want to bring up of, although we did find that urban areas were definitely more likely to refer for imaging, some of it was also insurance dependent, and Medicare was their primary patient population they were seeing and just not able to do it. So I wanted to speak to a little bit of my role as a clinician and not necessarily as a researcher. And so, as we were having discussions within our own clinic, the bottom right here, Ashley Russell, I have to give credit to. She was a recent grad of UMary, and she really led the efforts for this clinic to get imaging privileges within a small private practice setting. And so she actually provided me some notes here that I want to share with you all of like how the process looked for her and the persistence of how she was able to get this. And so the first thing she told me was it definitely took a lot of time. You have to be patient. This took about 6 months or so for her to even just get to the point that we're at today. She started back in October, November, and as of April, we finally have been able to be credentialed and ready to go. She sat down with all the physical therapists and really asked them their level of confidence and really had some in-services to bring everyone up to date and make sure we all felt comfortable with this. And then where she started, she just picked up the phone. She picked up the phone and started to reach out to all the different radiology departments within our area and our community. Obviously, some stopped pretty quickly, and some she was able to continue to speak to. And in fact, with one facility, she was able to get all the way to the CEO of that facility. And I have to give credit to Ashley. She was well prepared. She was well knowledgeable. She had the research to back up everything she was saying. And she was able to have a discussion with the CEO of this facility to allow us to become credentialed providers within their system to refer directly to their radiology department. And so we gave our NPI numbers. We did all the process to be able to do that. And about 3 to 4 weeks later, we were in their system. And then we spoke to the logistics, as we talked about, was a major barrier for some of these participants in the survey of how does this work? What information do you need? What the MOI, the mechanism of injury, what views, any sort of protocols we have to follow, how we would fax that over, how we would get that radiology report, et cetera, et cetera. And one thing to note was in having this discussion with the CEO, they wanted to make it really well known that we would be responsible and liable as a referring provider if any sort of finding was found, such as a sinister pathology. And we obviously welcomed that with open arms and felt adequately prepared to do that. And so that was probably the biggest discussion point that she had, is like, just make sure you're aware that you will be liable as a provider. And again, we took that on and we're not scared of that whatsoever. And then lastly, coming to the table and just speaking to this, like, well, what's in it for you? Well, you're going to have some of our business. We're going to refer to you specifically, and we're going to have that. And so this individual CEO welcomed our business. And as of today, we have the capability of being able to refer from a private practice setting, which is, I know, slightly different than I know some previous reports and discussions on university systems or, larger entities, hospital settings, things like that. So it can be done. It takes persistence and it takes some patience. And again, we were well knowledgeable and working towards that process. And what I can share is we definitely haven't been overwhelming the medical system since we've had this ability to do so. And one thing unique about this facility, as well as over 80 to 90% of our patient population at this clinic, is all direct access. And so we're definitely practicing to the full potential of our scope here. And it's been fun to have that ability to do so. So in conclusion, again, over 25% of our pretees in North Dakota in this survey are referring for plain film radiographs. That number is higher than most reported literature, so that's exciting to see. There's definitely several barriers that we identified that need to be addressed to get imaging privileges for all. I think one thing to note here, as researchers, we hypothesized kind of what we were going to find. As a clinician, I kind of had an idea of some of the results that we would find. Nothing really surprised us, but we were excited to just kind of bring this to the forefront for everyone to read and utilize and keep on the forefront to continue to progress for all, whether that's states that currently have it and just have to increase implementation, or states that are looking to get imaging referrals moving forward. And as I mentioned, having a doctor of physical therapy, specialized training, ortho and sports setting in urban areas definitely were found to be more likely to refer for imaging than not. Obviously, there are various factors in that as well. These are my references, and this is my son's favorite post, so I had to throw there. And so I just open up to questions, discussion. I'm excited to hear everyone's thoughts. And again, thank you for the opportunity to share what we found and some of my experiences here. So I appreciate it.
And thanks for sharing. This has been incredibly consequential as far as a presentation goes, and incredibly timely. What a great study and what a great presentation indeed. I feel like I've got my marching orders. because you gave us a menu of actionable items. I think there's so much to unpack in this, and frankly, I was always wondering about the urban versus rural, and my thoughts were going to be surely the rural stuff is we're going to be using it like crazy, and of course, I always thought private practice was going to lead the way because we don't have to contend with all these obstacles, with a bunch of these obstacles. You still have to go to the individual radiology clinics and all this sort of stuff. But I really thought now you made me understand the rural aspect, but you also gave me grist for the mill because really we need to tackle Medicare and our exclusion from the list of providers for this medical imaging. And what better argument that's saying that you're totally that our inclusion would benefit vast rural stretches of America. I mean, I think this is a linchpin argument, which I didn't consider before. So thank you for that. I gotta say, it's funny when one of the objections, or rather the obstacles are, well, I don't know how to order, and and my first foray into imaging ordering was simply picking up the phone and going like, what you need. My superpower is that I I'm okay with sounding like an idiot when I'm on the phone and 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 forgetting to put the diagnosis on the prescription pad. Uh, but I like mentioning this dirty little secret. When Seattle Radiology Clinic, when you refer, they have actually resources for the provider, and it's not meant for us. It's meant for the physicians. And there's like an 8-page cheat sheet on what to order, and a lot of these places have them. So, physical therapists might feel a lack of confidence, but this goes across all medical disciplines, and there's all kinds of help for you and resources. So, as I'm listening to with my dear colleague Mark Krimmel, who's also an RMSK, and we're going like, why don't you just look it up on the internet, for crying out loud? But just can't. I'm not meaning to run my suck on this, but it's fascinating. I need to get to Bill Boyson, who's got his hands up. Bill, what do you think of all this?
Yeah, thanks, Bruno. And Matt, congratulations with your colleagues on the publication and the really interesting work. It's really important benchmark data. I think it's great you added some qualitative data along with what you captured from the survey. So a couple of small questions. So you ended up having 147 responders. How many licensed PTs are there in North Dakota? I mean, what was your potential sample size?
Yeah. To be honest, that's a great question. I don't know that I know the answer to that fully, but I do know that obviously, and I think I see Cindy Mellon on here, so maybe she could speak to that a little bit as well. But I definitely, as a rural state, I know that we're definitely not as high as some of these other states, and so I've done a lot of mixed methods survey studies, and I've recognized how hard it is to get people to fill out these surveys, and so. I think when we sent this out through the North Dakota Board of Physical Therapy, we literally jumped up like 100 respondents within a couple of days. And so I want to say, I don't know the number on the top of my head, but I want to say that it's definitely not as high as some of these other previously reported or some other states. I see Sandy put in the chat here. I think we have about 800 licensed physical therapists. Yeah. I will accept that. I don't know that number on the top of my head.
Yeah, I think if your total sample potential is 800, so then you had a reasonable percentage. You have to be a little careful when you say that 25% of PTs in North Dakota did this when it was really 25% of your sample as opposed to all the licensed PTs.
Yes.
But yeah, survey fatigue is an issue. The last question or comment I had, I assume you didn't because it wasn't in your slide. It didn't look like you asked if responders were APTA members or not. Is that correct?
We did not. Although that was something that after we were looking even in some of the Lance Mabry stuff and seeing some of the data out there, just being an APTA member did seem to make a difference. And so that definitely was something that I think after the fact we were hoping we were kind of disappointed that we didn't ask that more specifically. But yeah, we did not ask that.
Yeah, I think that it might, in theory, tie into the lack of awareness not within our profession for sure. I mean, if you're not an APTA member, that means you can't be an Academy member, which means you can't be an Imaging SIG member, where all the great resources are. And, staying abreast of what's happening legislatively, if you're not a member, it's much more difficult to stay current. And in terms of resources to help educate, whether it's administrators or physicians, about our role and our report card to date, you just have to work harder to find the data, the evidence, if you're not a member as well. Chuck and I forgot to do that in our study, looking at surveying PT educators. I couldn't believe we didn't think of it either, but I hope that we all start including that as a question in our surveys, and because that may be a factor.
Absolutely. I think that's a great point. Definitely goes to show again the value of that membership and all the resources that you have to your fingertips. And so I agree. I think if there was something that I would do different, it would definitely have been adding that demographic data in there to look at specifically.
Yeah. Well, congrats again. Great work.
Thank you.
Cindy, you entered something in the chat. Can you just because the chat isn't captured in the recording, so can you please mention what you put down in the chat?
Sure. This is Cindy Flum-Allen. I am the president of the APTA North Dakota. So grateful to be here. Thank you, Matt, for sharing all of your information. And I just was agreeing with what he had to say. And we as APTA members have to continue to sell the benefit of membership and the knowledge and the things that we do to the non-members and the potential members. That's the better word than non-members always. So the other thing I would share with you, we are hoping, and the plan is for our next legislative session in North Dakota to work towards advanced imaging. And we know we have a huge battle going against the Medical Association of North Dakota, but do have the backing of the largest healthcare system in the state, which is really huge. So Bruno, I do plan to reach out to you because we could benefit from your assistance.
I hope so. I've been speaking with Scott Brown as well, and just to get our forces aligned. But the imaging resource documents and guides have been really incredibly instrumental in terms of using it as a rebuttal for the typical pablum and frankly crap that's ladled debate after debate. Whether we're fighting for direct access or imaging referral privileges and now diagnostic ultrasound imaging, it's always the same stuff. And that's the fun thing. Your prep is based on about 8 objections, and they keep asking it the same way. And as long as we craft that answer, I'd love to help you out with that. I'm having a little resource document fatigue, but we just completed yet another one for diagnostic ultrasound imaging. But right now, I want to address those 8 platitudes or those 10 platitudes that we constantly get. And that requires us to really reintroduce our profession, because it's really obvious that people don't even know what we do. We've had some states where the legislators simply go like, "You have direct access," and they want to relitigate that. So it's literally, we've created documents. In the case of Pennsylvania, for instance, we literally realized we're going to have to reintroduce ourselves, because it's clear they're not updated. They don't know a thing about our profession, and they need just a ground up, hey, this is what we do. We're primary care physical therapists. And it's an effective argument. So when you get in the room, I really want everybody to be more armed and ready for that response. And I think this is doable. I mean, Arizona proved it. They were really ticked off. I remember talking with their APT president, Brian Schmitz, and he just says, the next opportunity we get, we're going for it. But yeah, I'm sure with some metal and some prep material and dare I say role playing, I think this can be done. So however you need resources, I definitely want to be involved, and I'm engaged. Just deploy me as you will. So I'm looking forward to it. You guys deserve it, and I think you can do it. And I was thinking about the trend, even if maybe the sample size was small, Matt. I can't help but to think that most people will realize, as I've come to realize, that imaging referral is frankly, I don't mean to diminish it, but it's a nothing burger. It, come on. So I think when people I think the trend is going to be like, yeah, it's really no big deal. You're catastrophizing this. So I think the trend is your friend. I think this is going to catch on. I think it's a natural evolutionary step for us. So I really, and this whole idea is, I love how there's the people that says, well, it's your patient, you're liable for the patient. I'm going like, we're liable for every patient we work on. So it's just like, what, what it's kind of, oh, really? Oh my God, let me quake in my boots. There's always a reason for us to get a little too fearful. And, we're fearful enough with our patients. We take this seriously. We got into this health profession to deal with terrible conditions and keep it moving. But anyways, that's just my thing.
Yeah, no, I was just going to speak to that a little bit. We were talking within the clinic, and we've had a couple. I'm fortunate to help mentor some of our newer physical therapists that come in, and within a couple months, I mean, we identified some pretty scary things and referred out. And one of our new grads was basically contacting this primary care provider for the advanced imaging, and was like, hey, this is what's going on. This is the views I need, and this is what I think is going on. And she was spot on. And we sat down afterwards, and I was like, you're pretty much doing this already. You're just having to call this physician in order to do it instead of just doing it yourself. And so to your point, I think when I'm speaking to a lot of these physical therapists, it seems like a big deal, but the reality is we're doing this already in the sense of clinically reasoning through when to perform or when to refer for imaging, when not to refer for imaging, if it's going to change our plan of care, what views do you need, all those things, and you're already communicating that already. So just take the responsibility and go for it. And like you said, it's not really that big of a deal.
Yeah, and Matt, do you think that the radiologists, in terms of the feedback that you're getting, are you getting any anecdotal type of stuff on talking about whether physical therapists have a different flavor of ordering? Do we do something that's kind of nice, or do we tend to provide more mechanism of injury? What's their feedback? How do the radiologists like it so far? How do they like the interaction? Or there's nothing there. It's like whatever.
I mean, speaking to our clinic's experience, in the months that we've had it, we're tracking it. We have not sent a referral out since we've had the ability to do it, because we just haven't identified a need for it at this time within our patients. And so kind of going back to the argument, right, we're going to overwhelm this medical system. That doesn't seem to be the case, at least within our own experience. However, I would say, speaking within some, different individuals around the state, in those that are doing it, it seems like it's no big deal. And many times, my brother's actually a radiology technician, and he's like, sometimes I don't even know who's coming through it. It all seems to kind of flow pretty nicely. And so we're right in there. We're doing everything as other providers are doing, and getting what we need. So I've been seeing that and hearing different participants.
Yeah. Bill, what do you think?
Yeah, the implementation in your private practice was a great story, and congratulations. You're right. Implementation is the hard part. Getting the law passed is the easy part, in the long run. But being a private practice as opposed to hospital-based PT, any issues with reimbursement when you're referring patients directly to the radiology clinic? Because that's been an issue here in Wisconsin, I know.
We haven't, to my knowledge and recollection, we haven't had to make a referral. And again, we just recently got this, so it's just a couple months of having this within the clinic itself. But we haven't had to make a referral. We haven't made a referral at this time. So I don't have data specific to that. If we would be reimbursed or not.
Yeah, that's good. Any other questions for Dr. Schumacher? All right. Well, listen, this is basically going to be the end of our sessions until the end of September. This has been momentous, to say the least. I will once again thank you, Matt, for your participation and unbelievably actionable talk. Thanks to all our participants over the last year. And it's a little bit of a new year for me to be able to take a little break, at least from the presentations here. Still got a lot of work dealing with all the other states we're dealing with. I will leave you with this. Now that you got your state's privileges, now it's time to defend your privileges and use the evidence and be well prepared for the ritually stupid confrontations that you're going to face. And we're going to be dealing with some sort of a paper to deal with rebuttals and help you along with that. But I wish you all success. I think I've said this before, I think there's an inevitability in what we're doing. I think the trend is our friend. I think they need us. The worsening shortages with physicians and nurses, they're only getting worse. It's just happening. And this is confirmed by the hemoncs I'm talking with. They can't produce enough physicians. I think there's an inevitability. It's just a matter of we have to fight the good fight, be steady, and do what we have to do. Thank you for all the ideas, Matt. This just gave me a whole bunch of new homework, so thanks a lot. But seriously, this is fantastic. And I think this is very actionable stuff, and see how we can get the information out there for everybody, make it a little easier for them to realize that they can act on this. So
yeah, thank you very much. I appreciate it.
Thank you so much. Thank you for everything, everyone. Thank you, Bill Boysenall. Thanks, Cindy. Thanks, Annette. Eric. Thanks, iPhone. Sarah. I will see you guys in September. Please, anybody that wants to call me, please reach out any way you can, and I'll respond very quickly, I promise. Have a great summer, everybody, and a great 4th of July coming up.